I haven't met here in the room or attending remotely, I'm Jordan Marmet. I'm in the Division of Hospital Medicine. I'm joined by two brilliant colleagues, Dr. Sanchez in Pediatric Cardiology and Bryce Binstadt in Pediatric Rheumatology. And together we're going to present on Kawasaki disease, a timely update for more reason than one, as you'll see in a little bit. First, our disclosures is that we have nothing, no financial ties to, but we do have several off-label medications that we're going to be discussing, those listed here. And a quick legal disclaimer in that in the course of this talk, we will be discussing some quality improvement or process improvement directions. So our objectives, first of all, are that we can't have a talk like this without discussing classic and atypical presentation of Kawasaki disease. And so we'll have a quick reminder about that. And then we'd like you to leave here recognizing some key differences between the older American Heart Association policy statement in 2004 versus the new one in 2017 that was just released a few months ago. We'd like you to recognize the guidelines specifically in that 2017 scientific statement around echocardiographic follow-up and standard management of Kawasaki disease. And then for those patients who aren't responding in the way that we hope that they will, the second-line therapies that have more evidence now behind them. And finally, we'll close with some opportunities here for University of Minnesota. And please excuse us for talking quickly during the presentation. We tried to pack in a lot, as I mentioned. So now if you ignored the last 2 minutes of my presentation, and I were to tell you that there was a 15-month-old patient who presented in an ER or primary care setting with a parental complaint of 5 days of high fevers, and the physicians noted that there was a non-exudative conjunctivitis and a diffuse rash, some palmar or foot changes that might include peeling or swelling, some oral mucosal changes, maybe described as a strawberry tongue or cracked lips or et cetera, and swollen lymph nodes. I don't think anybody in this room would hesitate to jump out of their chair and say, that sounds like Kawasaki disease. But the more, and this in fact was right from the Kawasaki Disease Foundation homepage, but the more challenging presentation is when they come without reading the book and they have an incomplete presentation. So they have some of those signs and symptoms, and then we need to be more attuned to other kinds of, we'll see laboratory markers of inflammation going on. So that'll include things like CRP and ESR, maybe an elevated white blood cell count, thrombocytosis, elevated transaminases as well, and then some other subtle markers, so hypoalbuminemia and anemia in general. And then echocardiographically, we'll talk about more in a little bit, but they might have elevated Z-scores on their coronary arteries, ectasia, and some of those other findings listed here. And any of that should really push us in the direction of saying, yes, this is Kawasaki disease, and treat appropriately. A talk like this wouldn't be complete without a quick historical look and a nod to Dr. Kawasaki himself. Some of you in this room, I see Liz Bronlin here, Pat Furry I don't see today, but some folks know him personally. So he was the scientist in Japan, the doctor in Japan who first put together a case series of 50 cases that he recognized with a mucocutaneous ocular syndrome that was later dubbed Kawasaki disease. And then there have been three big, many papers, but three seminal papers that have helped dictate management over time. Those were in 93, 2004, and 2017, most recently by American Heart Association. And I'll point out just the length of these papers. So we started in 93 with a 5-page paper, and that's since exploded to a 25 and 74-page paper. So I hope that in the next iteration, in another 10 or 15 years, we won't be reading an entire textbook to figure out how to manage Kawasaki disease. So on to the incidence, on to why we should care about Kawasaki disease. In Japan and equally in Taiwan, we see a much higher incidence than we do here in the continental U.S. So this 2017 AHA paper had pulled together some of these numbers, and so 265, 100,000 kids under age 5 is the incidence there, which is about a 10-fold increase from here in the U.S., where we're seeing more like 25 or 30 per 100,000, depending on ethnic breakdown of patients. But I will point out that in Hawaii, there's a special difference that we notice based on ethnicity. So kids of Japanese descent will have an incidence very similar to what we're seeing in Japan itself, whereas the white or Caucasian kids have a rate even lower than here in the continental US. Mortality, why we should care about Kawasaki. Thankfully, mortality isn't a huge problem, but it is one that we can't forget about. And so the Japanese case fatality rate is far less than 1%. In the US, it's right around the same for hospital mortality. We do see that there's a peak risk of dying within the first 15 to 45 days, so like 2 to 6 weeks following initial diagnosis or initial presentation of fevers. But MI can occur even years later. Morbidity is a bigger problem than mortality, but we can't forget that piece. And it's also important to know that if left untreated, that we would see a full 25% of children developing coronary aneurysms. About half of those will regress spontaneously, but the other half will not. So out of that untreated cohort, around 5% are going to develop coronary stenosis with moderate to giant size aneurysms, and a smaller percentage will go on to have myocardial infarction and pass away. The extremes of age are important because of the way Kawasaki presents. So if you'll notice the graph on the left, we see this is looking at incidence and age on the X and Y axes. And so we'll notice a disparity between boys and girls, but in both populations we see a peak. I'm not getting my cursor here. Oh, there it is. So we're seeing a peak less than 1 year old, around 9 to 11 months for boys and around the same for girls in this particular study, and other studies bear that out. But most patients are falling under age 5 years. When we have those extremes of age, when we have children present under age 1 or greater than age 5, it's much more common to have an incomplete presentation, and inherent in that is we see later diagnosis, longer time to treatment, and as a result, higher rates of coronary aneurysms and complications. We can't forget about other things. We have to check our cognitive biases. But we do need to think broadly about, could this be a viral infection? Could it be something like adenovirus? Could it be strep throat? So something infectious. It could be something reactive or inflammatory in general. It could be staph toxic shock or Stevens-Johnson. We need to be thinking about rheumatologic or kinds of diseases like JIA. But we shouldn't latch ourselves prematurely onto diagnoses and have premature closure. So if we get positive viral testing for something like measles, we'll say, yeah, this is measles. But if we get something more common, if we're finding adenovirus positive, strep throat is positive, we shouldn't say, then for sure this isn't Kawasaki disease. Things like adenovirus, we shouldn't forget, can shed for quite a long time. And furthermore, we don't really know what is the final trigger for Kawasaki disease. We can postulate that there's a combination of infectious and biological things. From an infectious standpoint, we know that there's a seasonal pattern. So in case you weren't aware, it is Kawasaki season right now. So in the continental US, wintertime and early spring are times when we see more of it. And I know that there was a patient just discharged last week from the hospital with this diagnosis. In Japan, they also notice a significant increase within the first year of one child in a household having Kawasaki disease. Siblings are at a 2% risk. So I mentioned Japanese rate is around 165 per 100,000. If you have a sibling who's had it, your risk is 2% within that year. Much of those are present within of a sibling presenting. So point infectious trigger. Young children who pick up a lot of infectious things, as I mentioned, under age 5, most patients present, so maybe that leads to an infectious trigger. The boy versus girl, I just felt like that needed to be thrown up there, but that doesn't really point toward infectious or non-infectious. Genetic predispositions, as I mentioned, so high concordance in siblings. This is now talking not about 1 year, but about, in general, if there's a positive family history, there's about a 1% sibling risk, and it's much higher for identical twins. Rate of recurrence, so a patient who's already had Kawasaki disease has a potential to get it again, much higher than the general population. So on top, we have Japanese data. Below, we have US data that's just a little lower than the Japanese statistics, but again, pointing toward a definite genetic loading for this problem. Our current understanding of the pathophys, which we'll come back to again, but we believe that there's a necrotizing arteritis that takes about 2 weeks or so to set in. And that's as patients are moving into a subacute or chronic vasculitis phase. That takes quite a bit longer. That can start as early as 2 weeks, but can last months or years. And it develops into a luminal myofibroblastic proliferation, or LMP. We talked about MIs, but aneurysms can potentially rupture in the first few weeks from symptom onset, but most people are going to pass away from MIs due to the acute and progressive changes caused by that LMP. So with that, I'm going to pass to Dr. Sanchez.
Good morning. I'm Aura Sanchez. I'm one of the pediatric cardiologists, and my subspecialty is cardiac imaging, non-invasive cardiac imaging. And I'm not an expert on Kawasaki disease, but I do read quite a bit of echoes on patients with this disease. So in the next few slides, I'm just going to review the most recent guidelines regarding echocardiographic assessment of these patients, basic therapy, and follow-up. I'm going to start with this case. You're evaluating a 9-month-old male infant in the emergency department who presents with 5 days of fever, clinical signs concerning for Kawasaki disease. As part of your evaluation, you order an echocardiogram. So you ask yourself, what are the cardiovascular manifestations of Kawasaki disease? So Kawasaki disease can present actually with no cardiovascular manifestations, but also can present with pericarditis. It can present as myocarditis, and actually 20% of the patients can have decreased ventricular systolic function. They can have valvulitis, most frequently seen as mitral regurgitation in 25% of cases. Some of them can have transient dilation of the aortic root, and of course, coronary artery abnormalities, which incidence will vary depending on the time of presentation. So now we're going to focus more on coronary artery aneurysms. They most frequently involve the proximal segments of the coronary arteries, and those are the proximal LAD, proximal right coronary artery, left main coronary artery. In pediatrics, echocardiography is the main tool that we use to diagnose coronary lesions, but how well we can visualize them. So the Pediatric Health Network put together a multi-center study to evaluate patients with Kawasaki disease. And they reported a visualization rate that was more than 90% for the left main coronary artery, LAD, and proximal RCA individually. However, the rate of visualization for the other segments was not as good. In this study, they reported that practice, standardization, and sedation, especially of those children less than 3 years of age, improve the visualization of the most distal segments. So the American Heart Association states that the initial echocardiogram should be performed as soon as Kawasaki disease is suspected. But initiation of treatment should not be delayed while we wait for an echocardiogram. Sedation is frequently needed for patients less than 3 years of age, and may also be required in older patients if they are irritable. If the initial echocardiogram is poor, they recommend a sedated echo to be obtained as soon as possible within 48 hours after diagnosis and initial treatment. The guidelines also state that the echocardiogram that is obtained within the first week of life is typically normal. And this echocardiogram should be used as a baseline study for future comparison. So the size of the coronary artery aneurysms, as was already mentioned, has a huge impact on the prognosis of patients with Kawasaki disease. In 2004, the American Heart Association put together a classification based on diameter that used both absolute diameters as well as Z-scores. The Z-scores that I will be discussing today are going to be related to Z-scores of coronary artery diameters indexed to body surface area. In this classification, they define coronary artery ectasia as Z-scores between 2 to 2.5, and coronary artery aneurysms as Z-scores greater than or equal to 2.5. And there was then a subclassification of the severity of aneurysms based on the absolute diameters, as small aneurysms if they were measured less than 5 millimeters, medium aneurysms if they were 5 to 8 millimeters, and giant aneurysms if they measure more than 8 millimeters. So if we go back to our patient, 9-month-old in the emergency department whose BSA is 0.43 and has a proximal right coronary artery diameter of 1.4 millimeters, this will correspond to a Z-score of minus 0.6, and using the 2004 classification, this segment will be considered normal. However, if we have the same kid showing up with a right coronary artery diameter of 4.8 millimeters, this will correspond to a Z-score of 10, which is quite abnormal. However, per the previous guidelines, this aneurysm could be classified as small as it measured less than 5 millimeters. So this discrepancy between the magnitude of Z-scores and the absolute diameter classification from the previous guidelines and the potential risk for missing giant aneurysm in small children lead to a revision of these classifications in the most recent guidelines. The current classification uses Z-score to define coronary artery involvement. So now they define no involvement if the Z-score is less than 2, and there is no decrease in Z-score by more than 1 on follow-up programs. They define dilation if the Z-score is 2 to less than 2.5, or if initially less than 2, a decrease in Z-score by more than 1. Now, the definition of a small aneurysm is now is defined as a Z-score greater than or equal to 2.5 to less than 5. Median aneurysm if the Z-score is greater than or equal to 5 to less than 10, and an absolute diameter less than 8 millimeters. A large or giant aneurysm is now defined as Z-score greater than or equal to 10, or an absolute diameter greater or equal to 8 millimeters. So if we go back to the previous example, for a child whose Z-score is 10, in this infant, this aneurysm will be considered giant per the new guidelines. So despite the benefits of adjusting these measurements for body surface area, Z-scores are actually not perfect. They require measurement of coronary artery diameters that need to be accurate measurement of height and weight. There are also multiple strategies to calculate Z-scores with different formulas, normative data sets, and BSA calculations. Anatomic variations can also play a role. Those patients that have right versus left coronary dominance, for example. Another limitation is that Z-score measurements can only be applied to proximal coronary segments. Some of the systems do not include Z-score for circumflex arteries. And finally, fever can also cause coronary artery enlargement. So for all these reasons, it is important that you involve your cardiology colleagues when interpreting Z-scores on these patients. Another reason to involve cardiology from the beginning is because these children are going to require multiple echocardiograms. Most of the patients with Kawasaki disease start with normal coronary arteries, right? But they may follow at least 3 possible paths. They can either have no coronary changes. Some of them will experience mild transient dilation that usually results between 4 and 6 weeks. And some other ones will develop aneurysms. And those that have aneurysms are going to be at risk for occlusive thrombosis or complex stenosis, especially those that develop giant aneurysms. So when getting an echocardiogram, remember that a normal echocardiogram does not rule out Kawasaki disease. And visualization of coronary arteries are impacted by body size, acoustic windows, and patient agitation. Advanced imaging like CT angiogram may be recommended if there is severe involvement of proximal coronary artery segments in the acute phase. So how frequently should we order echocardiograms? The guidelines establish that for uncomplicated cases, those that have coronary artery C-scores less than 2.5 during the acute phase should have repeat echocardiograms between the first and second week and then subsequently 4 and 6 weeks after IVIG. If the patient has coronary C-scores greater than or equal than 2, they will need at least twice weekly echocardiograms until the luminal dimension stop progressing. So when should you consider consulting cardiology? I would say that anytime you diagnose a patient with Kawasaki disease, and also if you are considering getting an echocardiogram as part of your workup on a child for suspected Kawasaki disease. Let's go back to our case. So you made a diagnosis of Kawasaki in the emergency department, decided to admit the patient, and then my question is, what is the standard treatment for Kawasaki disease? And I believe everybody here will say that it's high-dose IVIG and aspirin. The efficacy of high-dose IVIG in Kawasaki disease has been very well documented. As in this summary table from this meta-analysis, high-dose IVIG decreases significantly the incidence of coronary artery lesions from 29% to 5%. The recent guidelines established that high-dose IVIG should be given within the first 10 days of fever as soon as the diagnosis is made. For those children that present after 10 days of illness, they should also receive IVIG if they have persistent fever without other explanation. They should also receive IVIG if they have coronary artery lesions on echocardiography with evidence of ongoing inflammation. So what about the other therapeutic agent that we always use? Aspirin. So the studies really have shown that neither low-dose or high-dose aspirin reduce the incidence of coronary lesions on Kawasaki disease. The current guidelines is that aspirin should be given at a moderate to high dose until the patient is afebrile. In the United States, we use high dose, which is 80 to 100 milligrams per kilo per day. What about the duration of high-dose aspirin? Well, the guidelines really do not specify. However, they acknowledge that there are differences in practice, with some practitioners using a short course and other ones a long course. What do we do here? So Carl Migali, one of our former fellows, actually looked at this, and he performed a retrospective review of 10 years. He identified 103 cases of Kawasaki disease with clear documentation of aspirin dosage. 35 of these patients had coronary artery abnormalities at the time of diagnosis. 17 out of these 103 patients did not receive high-dose aspirin, and the reason why is because they presented late, and by that time, by the time of presentation, they all have deferred best. Also, in his review, he didn't find any relationship between the duration of high-dose aspirin and the coronary artery C-scores on follow-up. This chart over here shows the duration of high-dose aspirin in each of the patients included. Over here, we have the patients that had no coronary involvement at presentation and those that had coronary involvement. And as you see, the patients received most of them received somewhere between 0 and 7 days of high-dose aspirin. But there was a good number of patients that received more than 20 days of high-dose aspirin. So there's quite a bit of variability. Going back to the guidelines, they that when moderate or high-dose aspirin is discontinued, low-dose aspirin should be started and continue for 4 to 6 weeks after onset of illness in all patients, and should be continued long-term for those patients with ongoing coronary artery involvement. So finally, we're going to get back to our case. This patient had a normal echocardiogram. We treated with high-dose IVIG and high-dose aspirin. He has been afebrile for 72 hours already and is ready for discharge. So what follow-up should we have for this kid? The reason behind follow-up on these patients is because of the coronary artery sequela. Even in those patients that have been treated appropriately with high-dose IVIG within the first 10 days of life, 5% can develop aneurysms, and 1% of them can develop giant aneurysms. The acute post-discharge management is key and should include monitoring for fever, resolution of inflammation, monitor for coronary artery changes and thrombosis, management of anticoagulation, and activity restrictions if indicated. This phase usually lasts 4 to 6 weeks. After this, the patients are transitioned into a long-term management phase. This usually occurs when the coronary artery scores are finally stable. The American Heart Association has put together a risk classification based on maximal extent of coronary involvement and evolution over time. This classification is quite complex and is way beyond the scope of this presentation. However, I would like to mention that it actually is used to determine the frequency of clinical follow-up, diagnostic testing, assessment of cardiovascular risk factors, thromboprophylaxis, physical activity recommendations and restrictions, as well as reproductive counseling in those patients. So in other words, the long-term phase management includes a multi-specialty expertise. So with all this, I will leave the next case to Bryce.
Good morning, can you hear me? Yes, good. Okay, so I'm going to pick up here and talk about this as a case example. So an 18-month-old boy with classic Kawasaki disease who receives the standard therapy that Aura just mentioned in terms of IVIG and high-dose aspirin. Initially defervesced, echo was normal, but then on day 7 of illness, fever returns as well as rash. And what do you do in this situation? And this is a challenge. And so I'm going to be talking about adjunctive therapies for Kawasaki disease and some recent studies that address what to do in this situation. And this is divided into 2 broad categories. So some studies have evaluated addition of therapies during the primary treatment of disease. So should additional agents be given with IVIG and high-dose aspirin during the initial treatment phase, and does that affect key outcomes? I'll talk about what those outcomes would be. And then for patients who do develop IVIG resistance, which is return of fever after the initial dose of IVIG, what can be done? And there's a high concordance. Several studies have showed a high concordance between patients who develop IVIG resistance and the later development of coronary artery abnormalities. And so these are used as surrogates, and some studies look at IVIG resistance as the outcome. Other studies look at coronary artery abnormalities as the outcome. But again, there's high concordance, and so I'm going to use them a bit interchangeably, but try to mention what the outcome is in each study that I mention. Several years ago, well, not several years ago. This was 3 years ago now. This was a multi-center study documenting across different centers, different children's hospitals, what is the rate of IVIG resistance, and the arrow points out where our hospital falls on this curve. And so you can see that overall the rate of IVIG resistance is somewhere between 10 and 20%. We are on the higher end of that. This is the reasons behind this are multifactorial. Maybe different populations that we're dealing with, maybe the care that's delivered, time to diagnosis and whatnot. But just for you to recognize that in this environment, the rate of IVIG resistance is on the high end. And of course, that correlates with a higher risk of coronary artery abnormalities. And so, first I'm going to talk about corticosteroids as adjunct to primary therapy. Corticosteroids are popular with rheumatologists because we use them to treat other types of vasculitis. And so, empirically, it's thought that corticosteroids would be useful in the treatment of Kawasaki disease, another vasculitis. And there are numerous studies looking at methylprednisolone either as a pulse dose, 30 milligrams per kilogram as a single dose, or as a lower dose multi-day course followed by an oral taper. And this, again, is in the primary phase of disease, or primary phase of treatment. And what these studies have showed in meta-analysis is that this can reduce coronary artery abnormalities in Japanese children who are at high risk of Ivig resistance or at high risk of coronary artery abnormalities. There's a caveat to this, which is that the scores used to predict risk are useful in Japan. They've been developed in Japan, but they don't really apply well to children in North America, and we'll get back to that. And so these are the scores. There are three main different scores: the Kobayashi score, the Agami score, and the Sano score. And you can see the and laboratory criteria here that are used to predict Ivig resistance, and these are used to classify patients into low or high risk, and are used in Japan primarily. Based on evidence, this is from the new AHA statement advising what to do with methylprednisolone. So the new statement states that single-dose pulse methylprednisolone should not be administered with Ivig as routine primary therapy for patients with Kawasaki disease. But that comes with this caveat that administration of a longer course of corticosteroids may be considered for treatment of high-risk patients with acute Kawasaki disease if they're at high risk. And so this gets into the question of how do we identify the patients who are at high risk, and currently in North America we're not good at identifying those patients at the time of presentation. You'll, I think, hopefully not be seeing people using methylprednisolone or other corticosteroids early in the course of Kawasaki disease. I'm going to transition now to sort of what's up and coming in treatment of Kawasaki disease and talk about biologic medications. We use these all the time in rheumatology. The main agents that we're using, so these are monoclonal antibodies or soluble receptors or naturally occurring antagonists that block these key pro-inflammatory cytokines: tumor necrosis factor, interleukin-1, and interleukin-6. First, I'm going to focus on TNF. And so this is a large study based in 2 U.S. centers of 196 patients between 4 weeks and 17 years of age. This is using IVIG plus aspirin, and then patients were randomized, again, in the primary phase of treatment to either receive infliximab, a monoclonal antibody against TNF, or placebo. So they received intravenous placebo in this study. And the primary outcome in this study was IVIG resistance. Does infliximab reduce the incidence of IVIG resistance? And then several secondary outcome measures were also included, and I'll review those. And so, again, 196 patients were randomized, and in terms of the primary outcome, this is what the study authors found. The rate of IVIG resistance in the patients that received infliximab was around 11%, and exactly the same in the placebo group. So there was no difference in reducing IVIG resistance. I'd point out here that the rate of IVIG resistance in the placebo group here is on the low end. I showed you it typically ranges between 10 and 20%. So that this study is complicated a little bit by dealing with a population that already has a baseline low IVIG resistance. But this is the primary outcome of the study, and this is what has been this is the finding that's been incorporated into the new guidelines. With respect to secondary outcomes, a common complication of giving IVIG is that patients will have infusion reactions, allergic type reactions during the IVIG infusion, and this did not occur in any of the patients that received infliximab, compared to around 13% of the patients who received placebo. So that's a nice secondary benefit. It's an expensive one, but it's a nice secondary benefit of giving infliximab. With respect to days of fever, there was a statistically significant decrease in the number of days of fever in the patients who received infliximab. But if you look at the absolute values here, this is 1 day of fever compared to 2 days of fever. So whether this is clinically meaningful or not is unclear. It did not shorten the duration of hospitalization. With respect to coronary artery abnormality development, what you can see at the 2-week time point, so 2 weeks after treatment, there was a statistically significant decrease in the rate of, or in the coronary artery Z-scores in the LAD in the infliximab treated group compared to the placebo group at 2 weeks. But if you look out at 5 weeks, that difference goes away. You'll see that there is a trend at both time points toward the infliximab group having a greater reduction in Z-score than the placebo group, but the study was not powered to look at this outcome. So it's possible that with a larger study could show a benefit of infliximab treatment. With respect to the right coronary artery Z-score, there were no differences at any of the time points studied. And then just a quick slide in terms of the laboratory parameters that are followed. You can see that the absolute neutrophil count does go down in the infliximab treated group compared to the placebo group, again at the 1 day time point, but that difference disappears at 2 weeks. And similarly, the CRP behaves the same way. So there's a quick reduction in fever and inflammatory markers, but that doesn't appear to affect long-term outcomes. And so on the basis of that study and a couple of other smaller studies, the new scientific statement says that the addition of infliximab to initial therapy with IVIG is safe, but does not prevent recrudescent fever. And so it's not advised to routinely give infliximab in the initial therapy phase. I'm going to transition now and talk about what do we do for the patients who do develop IVIG resistance, and what's the role of various medications in this context. And I mentioned already that the Japanese risk scores for IVIG resistance do not perform well in North American patients, US and Canada. And so this is a big gap in our understanding, I think, is figuring out what are the good predictors of risk for coronary artery development and IVIG resistance in North American patients. The new guidelines include a table of treatment options for patients who do develop IVIG resistance. I think just to run through these, the most commonly prescribed medication in this situation is to simply give a second dose of IVIG. And for some patients, that's adequate, and that will lead to resolution of fever. Also commonly given is methylprednisolone at this stage, either as a pulse dose or as a several-day course. And what's suggested in the guidelines is a several-day course there. And there's reasonable evidence that will lead to resolution of fever. And then other studies that I didn't present will looking at infliximab use, so blocking TNF can be used for IVIG-resistant patients. And then there are other options listed below: cyclosporin, anakinra, cyclophosphamide, and plasma exchange. And the cyclophosphamide and plasma exchange are really for the most severe cases, typically where some of these other second-line agents have already been tried and have not been successful. So several options are listed. I want to talk about one of these in more detail, and that's Anakinra. There's a lot of excitement about Anakinra. This is IL-1 receptor antagonist. It's a protein that all of us make naturally, and this is a recombinant version of that can be given. We use it for several diseases in pediatric rheumatology. There's excitement about Anakinra in Kawasaki disease based on both animal models of the disease as well as gene expression studies from human patients demonstrating that there's upregulation of IL-1, particularly in the aneurysmal lesions. And so there's a large ongoing study looking at the use of Anakinra in infants and children who have coronary artery abnormalities in the acute phase of Kawasaki disease. And I think there's big hope in the field that this will, for a good outcome from this study, demonstrating that it's that's effective, but this is an ongoing trial. And then lastly, I want to bring to your attention this recent report. And so this is dealing with tocilizumab. This is an IL-6 blocking monoclonal antibody. As rheumatologists, we tend to think of TNF and IL-1 and IL-6 exerting similar pro-inflammatory effects. Tocilizumab, the IL-6 blocking antibody, is FDA approved for the treatment of another type of arteritis, giant cell arteritis. And so it's reasonable to think that it might work in Kawasaki disease, it's a disease that affects similar sized arteries. And so this is a sort of surprising study that was being conducted in Japan, I believe. And they were doing a prospective study to look at Ivig resistant patients and asking whether the addition of tocilizumab would help those patients respond. So all of the patients, they had 4 patients. They cut the study short for reasons I'll explain, but all 4 patients had persistent fever after getting IVIG. None of them had baseline coronary artery dilatation. Their fevers all went away after they received tocilizumab, but surprisingly, 2 of the 4 patients treated with this developed giant aneurysms, one of which persisted and one of which regressed. And so this just shows what happens with the fever going away. The top graph shows the fever going away after tocilizumab, laboratory parameters improving, but then development of coronary artery aneurysms shown on the top. So this, I think, is a warning to us as rheumatologists, who are typically the ones getting to think about these additional fancier treatments, that what we learn from one type of vasculitis may not translate into Kawasaki disease, and the large studies really need to guide our rational choice of which agent to choose. So the message I would leave for this audience is that if you have patients who are IVIG resistant or who have coronary artery abnormalities and you feel that they need adjunctive therapy, please consult pediatric rheumatology. We love to get involved in these cases, and feel free to call us. I'm going to turn it back over to Jordan.
So a few opportunities that we have here at our own local center. I hope that people are aware, if you're on the front lines taking care of Kawasaki disease patients, that we do have a few things already in place to drive standardization. We have an order set, and I'll distinguish order set from order panel. So from 2015 onward, we've had an order set that was designed for admitting a patient. So they're seen in the primary care setting, they're seen in the ER. We've made a diagnosis of Kawasaki disease already. So it includes management and admission, et cetera. We have order panels that are designed more for patients seen in the ER. They're making a determination of sick, not sick. They decide patient is sick, need to be admitted for further evaluation and management. We decide it's Kawasaki disease, and at that point, we want to do a specific workup for Kawasaki or specific management. And so these will drive some standardization, and I'll show you what those look like in a moment. And then IVIG as well has been put into an order panel so that we have some standardization around dosing and other orders that are pre-meds, et cetera, that are supposed to be accompanied with it. Another opportunity is just around cardiology involvement. Aura was talking about some standardization of echoes, and we have opportunities there, as well as contemplating sedated echoes potentially for all children under age 3 years old to get good, high-quality views of the coronary arteries. Additionally, some centers have moved to having a Kawasaki disease team that's consulted for cases of Kawasaki. That might be by telephone, it might be in person, and it might be a combination of cardiologists, rheumatologists, ID, and or hospitalists who are a small group of people who are involved in managing, for instance, the discharge teaching. So really pushing that message to families how important follow-up is, how important compliance with the medication regimen is, even if their child doesn't like the taste of the medicines, et cetera. and even can be involved in follow-up issues. So having phone calls to families, ensuring that they follow up appropriately with specialists. Participation in registries would be another opportunity. There are some centers like UCSD in particular, or even a whole Canadian registry that's in place. And so, as we three and a few other folks in the department have met, we've talked about really collecting our data better here locally. And using that to inform us. This is what one of the order sets or panels look like. So if we go into not the standard orders, but click on the order set tab within Epic, and if you type in Kawasaki, these are going to look blank, but down here on the bottom, don't ignore where it says order panels. And down here we can see that there's a Kawasaki disease treatment panel and a workup panel that are there and available. And one of the things that I'd like to do with a few med students is to dig back and look at how often have we been using these order sets and order panels, because maybe there's more room on education of folks who are doing it. This is what the treatment panel is going to look like with IVIG specifically. And so here, for instance, we might forget about some recommendations to families around live virus vaccines. So some of these things, Epic can let us pre-check and not forget to do. Here, cardiology consultation is already pre-checked in there. So driving more standardization that way. So a few last take-home points, and then we'll open up for questions. If there's nothing else that you leave here today, remembering, we hope to impress upon you that a normal echo absolutely does not rule out Kawasaki disease. And so we should refrain from thinking about that. We should refrain from writing about that in our notes. Positive viral testing also doesn't exclude Kawasaki disease or strep throat, for instance. We shouldn't have premature closure or cognitive bias and that kind of thinking. We should keep our mind open to Kawasaki. And then lastly, when considering a diagnosis of Kawasaki, we should already be thinking about maybe not just ID involvement, but cardiology involvement, so that we get the right studies and the right follow-up for these patients, and really get the message to families how important of a disease this is in the long run, not just in the immediate phase. And then when we have complicated patients who aren't responding the way we want them to treatment, or when we want to think outside the box, involving rheumatology as appropriate, as Bryce mentioned, can be really important. So with that, we'd like to open up to questions that the audience may have.
Very nice presentation. I have sort of three short ones. I was surprised that nobody mentioned extra coronary involvement, the systemic involvement with Kawasaki disease, and somebody might want to do that. The second one is, you used the word follow-up, and there was 1 to 2 weeks and 4 to 6 weeks or so forth. How long have echo studies been done that are credible to look at the really long-term follow-up of these patients? And finally, if you did those studies that you very nicely covered in patients with atypical Kawasaki's, is there a difference with those with bona fide Kawasaki's?
Well, regarding the first part of your questions, as far as involvement in Kawasaki disease, we know that other medium-sized arteries can be involved. I didn't go into those details because I wanted to focus on coronary sequelae, and that's why I sort of didn't touch on those. Usually, if we assume that there are coronary aneurysms in the coronary arteries, there is increased risk of having involvement in other arteries in the body. The second part of your question, I didn't quite understood, as far as you mentioned how far that we have looked at. I would say For echo follow-up, patients with coronary, I mean, there are studies that have followed patients up to 15 years or 20 years after they presented with Kawasaki disease. And those that never have, for example, coronary dilation, we know that it's extremely rare that they're going to have coronary ischemia down the road. But those that have, for example, coronary aneurysms, up to 50% of them can have a coronary event within the next 15 years. So we know that.
Versus typical, atypical versus typical Kawasaki disease in terms of the various treatments and outcomes. I think that the challenge with atypical disease is that those patients are typically identified later, and so their rates of abnormalities and complications tend to be higher than patients with typical disease. But it's hard to separate out because it's confounded by delay in diagnosis. But I'm happy to have others comment on that. There are other experts in the audience here.
This is a question, I think, for Bryce, but given what is or isn't known about the inflammatory process in Kawasaki disease, when can one relax? What I mean is, when does Kawasaki disease cease to be the context for interpreting a fever in a young child? Is it 2 weeks out, a month out, 2 years out? When does that no longer become a relevant consideration for treatment? So we know that a child who develops fever within 48 hours of IVIG is probably resistant and needs some alternative form of therapy. You talked about doing it a week out.
Oh, I see. Yeah.
When a child presents having had Kawasaki disease a month later with a fever, do I still have to interpret that in the context of Kawasaki disease? When can I stop?
Yeah, that's a very good question. I don't know that there are data to guide that. I think I would still be concerned within the first month of disease. That it could be recrudescence of the Kawasaki disease. Certainly if they're still in the phase of being on low-dose aspirin, I would be concerned. But at that phase, they're still hopefully scheduled for routine echocardiographic follow-up, and that would be happening anyway. But I think if that happens to your patient, I would get them back in touch with the providers who are following them.
Have you been or will you be ordering any cytokine testing in order to help guide which adjunctive therapy to use and the response to that therapy?
We don't typically do that. That's certainly being done in the context of these trials of the anti-TNF and IL-1 blocking agents. The challenge is that the systemic elevation of cytokines doesn't necessarily occur. It's a localized process, and so some of the studies are coming from autopsy studies, or some of the data are coming from autopsy studies. And if you look at TNF and IL-6 and IL-1, they're sort of elevated across the board, but based on the data I showed you, targeting some of those might be more effective than targeting others, and targeting IL-6, there's a risk signal. And so it's hard, I think, to use the cytokine data to guide therapy with our current level of understanding. So no, it's not routinely done. It is done in the context of studies. John?
So I just wanted to make a couple of quick comments. I have 2 patients who developed silent coronary artery stenosis in their 20s and 30s, and so this idea that the echo is okay, the patient must be okay, is not true, and this is the reason that these patients need to be followed long term. There's certainly some enthusiasm for controlling lipids in adults who've had Kawasaki disease, whether they have coronary involvement or not. And so just a normal echo is not a normal patient. And my second comment, I think, has to do with this group that you're trying to organize. I think if we want to have consistency in the way we diagnose Kawasaki disease in our patients, and consistency in the way they're treated, that you have to have this group organized. And so I would just like to beg that you put it together and make it go forward. I'm not sure what needs to be done to make it happen, but you should do it.
We're working on getting the right people in the same room to formulate that team and to get buy-in from the key groups. Pat? Oh, sorry, Brad. Whoever has the microphone. Brad?
thought that was a great presentation. Having attended several of the Kawasaki International meetings over the years, I'm always struck by new biomarkers that look tantalizing that are presented frequently by Japanese investigators. But they tend to peter out, and nothing ever rises to really prominence and sustained interest or applicability. I didn't go to the recent one in Yokohama. Liz, did you go to that one? Pardon me? Not yet. But anyway, what is your take? You know, the basic pathophysiology is not precisely defined. We don't know what triggers the cardiopathy, arteriopathy, et cetera, and we don't really have good diagnostic tools. So what is your take, Bryce, on the state of the art at the moment?
Well, I think that's similar to Angela's question in terms of what are the key biomarkers. And like you point out, there's been enthusiasm for various biomarkers over time, but none of them seems to perform well in clinical practice. You may see a statistically significant difference in a certain biomarker in a study of a small number of patients, but when you get to asking whether that performs in clinical practice, I think the enthusiasm wanes because the turnaround time for many of those studies is currently too long to affect clinical decision making. And so as that time frame shortens, I would hope that we could put some of those markers to better use. But I don't think we're there yet. And so that's part of the discussion of what are the predictors of risk for coronary artery abnormalities or for Ivig resistance. Certainly some of those newer biomarkers and cytokine levels and whatnot should come into play in there. But until the practical clinical turnaround time is fast enough to affect clinical decision making, I think it's going to be hard to implement them. Yeah, but then we should start doing it.
So I just wanted to ask, since the treatment that we've talked about here is so important to start early, and I think this is an effort to raise awareness of atypical Kawasaki and how do we make the diagnosis. What are the efforts as part of the group to make sure that diagnosis is being made as early as possible in terms of particularly the atypical and it's not strep, even though we think they're strep positive. So what are the efforts there?
So I think you're witnessing one of the efforts here is education, and then broadening the thinking, so involving more specialists, involving our cardiologists earlier, to help drive, as I mentioned, the accuracy and the good quality echoes. So Ara, you mentioned that sometimes you'll get an echo order and it just says fever, and so the echo techs and cardiologists might not be paying attention to the coronary arteries, and I'll let you speak more to that as much as they should. So broadening the thinking, recognizing our cognitive biases. Not discharging patients prematurely with, we see some white blood cells in the urine and we call it a UTI and send them home. I'll let you elaborate on that.
I think that, I would agree with everything that Jordan just mentioned. From our perspective as cardiologists, I think that we need to be communicated. Many times ordering an echo without a clear indication is a problem. These patients are irritable, especially the younger they are. Many times visualization is very challenging. So if there is no clear communication about what the question is, we may not be able to give you the information that you need, or we may not help you set up a sedated echo or something like that. Even like that, even considering that past the acute phase, the echocardiogram can be completely normal. And that follow-up is also key. So I think just having awareness that the diagnosis of Kawasaki, even though you may not be completely sure about that moment when you're seeing the patient, actually later on, the patient can present with more manifestations or may have an abnormal echocardiogram later on. So I think that for all these reasons, we just have to be aware and keep our minds open when we're seeing a patient with possible Kawasaki disease.
Can I just add to that? I was so pleased the other day. I was having a conversation with one of our emergency physicians, and she said that when she sees a patient with fever, the two things she doesn't want to miss are sepsis and Kawasaki disease. And so I was so pleased to hear that. Like, the level of suspicion has to be high, recognizing that viral infections can masquerade as Kawasaki disease and do not exclude the diagnosis of Kawasaki disease is key. And so just keeping that level of suspicion, high level of suspicion, is key.
I would like to congratulate you on your development of a working group for Kawasaki disease. I wanted to let you know that we are part of the North American Kawasaki Disease Registry, so we enter data. There's probably 1,400 cases now from North America in the registry, and ours are part of those cases. I think that going forward, I would hope that, like Brad suggested, we know how to treat Kawasaki disease. What we need to do is increase our ability to diagnose it. Cardiologists are, I think, pretty quick to pull the trigger on treating Kawasaki disease because we see the results of untreated Kawasaki disease so I would hope that things could be employed, even something as simple as one of our fellows, Kieran, mentioned that a script for a patient who presents with 4 or 5 days of fever, the intake nurse could ask for the symptoms of Kawasaki disease as a point of awareness, just like we did for Ebola for 6 months or so. And I think that might be something that you three as a group could work towards making happen.
We have a couple more questions. We're over time, but
so I'm interested in the genetic predisposition to Kawasaki disease. Thinking about the Asians in Japan, Taiwan, I'm kind of interested in the question about whether or not you've noticed any ethnic predisposition here in the Twin Cities, where we have a large Southeast Asian population, for example, whether there's to consider maybe some genetic studies, et cetera, in the future. I haven't really seen very much done regarding that, even in the Japanese literature, although I can't say that I've combed it carefully, but was just wondering what your thoughts are about that.
So I'm not aware of any specific genetic markers that have been identified that we could track here, but it would certainly be interesting to look into our own experience in ethnic breakdown. So we have some students that are going to be looking into our experience here, so tagging on to what was done previously in the Division of Cardiology, looking at our experience over 10 years, and looking at ethnic breakdown may be interesting. Patients aren't required to fill in that ethnic blank in EPIC either, so there is that caveat too, that a lot of times it's left blank. And we're left guessing based on names, which isn't perfect.
One more.
So just maybe another take-home message type of thing. There's increasing evidence in the literature, especially in the Japanese literature, to premature atherosclerosis in patients, in young adults and older adults, but definitely in the young adult population, in patients who had documented Kawasaki disease, even in the absence of coronary artery aneurysms that were detected during the acute phases of the disease. And it is to a point that the WHO and the American Heart Association have recognized patients with Kawasaki disease to be at high risk for premature coronary events. So for our, not just for this group, but definitely it would be a good educational point to the primary care physicians that as they follow these patients longitudinally, even if they were cured, so-called, of the acute phase of the disease, these patients, these individuals are not heart healthy. That is, their coronary arteries are not in perfect shape, and therefore early control of risk factors, including cholesterol and overweight and unhealthy lifestyle, is actually paramount and is recommended by guidelines.
Yeah, that's an important point. Thank you.
Thank you, Julia. That comment on long-term management, importance of follow-up, is a great place to end. Thank you all for coming today. Thank you.
You have been disconnected from the meeting.